My name is Rachel Root. I am a psychologist. I work at, I have a practice at Treasure Valley Psychology in Boise. I'm also so I have a certification in perinatal mental health, hence this presentation today. So a few things while Shannon is pulling these up. A couple little disclaimers really quick for you guys. So I have this cough that won't quit, and so I'm going to try really, really hard not to have this coughing fit on today's session. It's going to be a real fun ride for all of us because it's obviously, and as usually, it's triggered by talking. So we'll see how this goes. And Shannon, thank you for muting me if I don't get to it first. So anyway, before I get started, though, I wanted to tell you guys that today's presentation is going to be a little bit of an introduction to a larger and broader topic, or to this large and broad topic that we are going to dig into detail next year. We have an 8-session block that's coming up starting in January and running all the way through April in this ECHO, the Behavioral Health and Primary Care ECHO, that is going to be on perinatal mental health. And it's going to be covering a lot of topics in a lot more depth. So today is really just going to be an introduction, and hopefully it will get you excited and intrigued to join us next year. All right. Go ahead and go to the next slide for me, Shannon. All right, so today's objectives are pretty clear. Just an introduction, like I said, of the perinatal mood and anxiety disorders. I'd also like to discuss some of the effects of untreated mood and anxiety disorders, both in pregnancy and in the postpartum space. And then there are some really, really helpful screening tools that can be used, that can be easily used in practice. So I'd like to go over some of those, make sure that everybody has access to those, talk about how you might be able to start utilizing those in your own practice, and then maybe discussing some resources that you can also utilize to get a little more information on this topic. So first couple of things I think that are really important. Oh, next, thanks, Shannon, you know what to do. All right, so I think some terms are really important. So I wanted to talk about what the term perinatal is, right? So perinatal is the time frame from conception all the way through at least the first year after giving birth. So essentially, this is about a 2-year time frame. Everything that we talk about that is perinatal is within this time frame. It's all of pregnancy, all of at least the first year after birth. And a lot of times when we talk about these perinatal mood and anxiety disorders, we only talk about postpartum. And often that only refers to, or often refers to, depression. So a lot of times people will really focus on the postpartum depression side of things. And it's not, the perinatal mood and anxiety disorders are not just postpartum depression, not just PPD. There are so many other aspects to this broader topic that are really, really important. So I think a lot of times we use that term postpartum. Oh, did you experience postpartum? And that term is so broad, but I think a lot of times just in conversation, we use that to refer to postpartum depression, even though there are so many other things that we can experience and deal with as providers in that entire perinatal space. So some of the perinatal mood and anxiety disorders, that term itself, and the little acronym for that is PMADS. So if you hear me saying PMADS, that's what I'm talking about. It encompasses depression, perinatal bipolar disorders, anxiety or panic disorder as well, obsessive compulsive disorder, and post-traumatic stress disorder, also psychosis. And so some of these things you may have heard of a lot with the postpartum depression, postpartum psychosis, things like that. But all of these are really included underneath that umbrella of PMADS. Next slide, please. All right, so this slide is very it's very word heavy, so bear with me. But I feel like this is really important information. So just some things to kind of let you know about the about perinatal mood and anxiety disorders. The perinatal period is the highest incidence of mental health intervention across a woman's lifespan. So in that time period between, conception and all the way through the first year after birth is the highest incidence where we are seeing mental health struggles and mental health interventions across the entire lifespan for a female. Also, PMADs are the number one most common medical complication related to childbearing. And I think for some people that might come as a surprise to have that statistic out there, because we think of all of these other physical complications and medical complications that happen with pregnancy and with delivery, but perinatal mood and anxiety disorders are the number one most common medical complication. PMADs also affect 1 in 5 women, so that's about 800,000 women each year in the United States. And even with that being said, 75% of women who experience those symptoms that are consistent with perinatal mood and anxiety disorders go untreated. So logic would tell us that that number is likely higher in men or non-birthing parents as well, because we tend to put as little focus as we tend to put on birthing parents, we tend to put even less focus and attention on non-birthing parents. So a lot of this goes untreated. A lot of it goes, unidentified even. So this is something that is really important for us all to understand so we can start to recognize when some of this is happening in our practice. So of the women who develop perinatal anxiety or depression, about 27% will enter pregnancy already having a standing kind of anxiety or a depressive disorder. So 33% of those, though, will develop those symptoms during pregnancy. And then 40% will develop those symptoms postpartum. So it can happen at any stage. You can come into the perinatal space with a mood or anxiety disorder. It can be developed within pregnancy, and it can also be developed postpartum. So one thing that I think is really important to know too is that suicide and overdose are the leading causes of death in the first year postpartum for women. So, and 100% of those deaths are deemed preventable. This is a really sad statistic. All of these are really sad statistics. But unfortunately, those are the leading causes of death in women postpartum. Next slide. All right, so for perinatal mood and anxiety disorders, we have a couple of risk factors that I think are important for us all just to be aware of as we're seeing patients in our practice that are within kind of those childbearing years, or their family is thinking about having more children or having their first child. And so these are some of the risk factors that we want to be looking at that can put someone at higher risk for development of a perinatal mood or anxiety disorder. So first is a history of mental health disorders, right? This can be a personal history, family history, or in particular, a history of perinatal mood and anxiety disorders in previous pregnancies certainly puts someone at a higher risk of developing those in subsequent pregnancies. Also, we want to be looking for a lack of support, particularly from their partner. So what we see with this lack of support, it's most prevalent when there is insufficient support with their partner, but also if there's local friends and family support that isn't there or that's lacking, or community support that is lacking, that also can be a risk factor. Also, folks who are a little bit more sensitive to hormonal changes or perhaps endocrine dysfunction can also have a higher risk for developing PMADs. So these are our patients with either thyroid dysfunction or a history of mental health struggles in puberty. Sometimes folks that we've identified as having a sensitivity to hormonal birth control. And then also, I think it's important to note that folks with a history of PMDD also have a higher incidence of developing a perinatal mood and anxiety disorder. So that is something that we have seen kind of go hand in hand. So if you have a patient who you're working with who has struggled with PMDD in the past, just kind of keep that on your radar, that can be a bit of a risk factor. Also, high stress parenting, right, also really can put someone at a higher risk for developing PMADs. So examples of this would be parenting of multiples. medically fragile children, military families, or teen parents. And also single parents are 2 times more likely to develop a perinatal mood or anxiety disorder. And then, and then not lastly, because it's not an exhaustive list, but trauma is also a huge risk factor. Whether there is a history of trauma, or if someone sustained birth trauma, either birthing parent or non-birthing parent can experience birth trauma. NICU stays are typically a pretty high trauma-inducing event. And so if any of those things were there, it can certainly put someone at a higher risk of development of these types of disorders. And then there are also some compounding factors, right, that can influence how this shows up for folks. Those things can be number one, and this is huge in my practice, is sleep deprivation, right? So we all know that in order to be a functioning human with a functioning brain and body, we need enough sleep. It's also one of the most difficult things to come by in the perinatal period. And so it becomes a little bit of a tricky dance when working with the perinatal population, making sure that their sleep is protected. So sleep deprivation is definitely a compounding factor. Pain, breastfeeding struggles. A lot of the folks that I work with are surprised by what an impact breastfeeding has, whether that's the social implications of breastfeeding, right? Feeling a lot of pressure to breastfeed, feeling a lot of pressure to feed their child with breast milk, with, you know, through bottles or by nursing directly, or someone who really wants to breastfeed and can't, or is struggling to do so. So there's a lot that goes into that, and it is often a surprise at how impactful that is for folks. So that certainly can be a compounding factor. Childcare stress, right? I'm sure many of us are not strangers to that. Childcare stresses, relational difficulties, right? If they are having difficulty in their marriage or their partnership, or with their outside family, right? With grandparents that are in the picture, that can really be a compounding factor. If there are health concerns in either any of the parents or baby themselves, that obviously can be a compounding factor. Baby's temperament. If you are someone who has a colicky baby, that can really, really be a high risk for development of some kind of perinatal mood or anxiety disorder. It's a really, really stressful environment. Family of origin issues, and then also this idea of returning to work and balancing work for both parents. So these are things that we want to be looking out for when we're treating this population. Next slide, please. All right. So we want to get into some of the untreated effects, right? So what happens, what are we risking when we don't treat this? I think historically there has been a nervousness sometimes with treating pregnant, treating with pregnant folks, particularly when we're talking about medications and things like that, which is not my zone, but certainly it is something that becomes a little bit of a tricky dance. And so I think what we also really, really need to look at are what are the risks, not only what are the risks of treatment, but what are the risks of not treating? What are the risks of letting someone white knuckle through some of these difficulties? With depression, and I'm going to focus first on some of the risks in pregnancy, okay? Kind of split up pregnancy and postpartum. But looking at pregnancy, some of the risks of untreated perinatal mood and anxiety disorders in pregnancy. So with depression, we look at a risk of poor self-care, nutrition, and sleep. Increased risk of suicide, right? We know that that is a higher risk with untreated depression. Negative effects on bonding in utero, right? Being looking forward to the baby, feeling connected to that baby. Sometimes non-compliance with prenatal care in general, which is a huge risk. Also, depression, untreated depression, and I'm going to highlight that word untreated, right? Untreated depression in pregnancy has been linked with preterm birth, low birth weight, preeclampsia, and gestational diabetes, and some different effects in those areas. So some of the effects with anxiety in pregnancy are we see increased cortisol levels in the fetus. We see a disruption in the developing brain circuitry, and also that hormone system in the fetus. So, if mom is not doing well and is having these struggles with anxiety while she's pregnant, those effects are going to translate to the development of her baby. We also see that same risk of preterm birth, a shortened gestational age, and then also low birth weight with anxiety, untreated anxiety in pregnancy. And then some of the effects of untreated bipolar, and particularly the mania phase of bipolar in pregnancy, are some of the consequences of these risky behaviors that we see in mania, like unprotected sex, increased risk of substance abuse, right? Some of those risky behaviors and impulsive behaviors, a decrease in self-care, prenatal care as well. And then sometimes a real difficulty with realistic preparation for baby, right? If someone is struggling with mania in pregnancy, I mean, I think anyone who has been pregnant or had a child or experienced someone who has gone through a pregnancy knows that there's quite a bit of planning and preparing to do. And so some of that goes to the wayside, and that realistic preparation can really, really be undervalued if we have someone struggling with mania. All right, next slide, please. All right, so now I want to focus on some of the effects of untreated depression, specifically postpartum, okay? So when we see depression postpartum that is untreated, this can be a huge factor with difficulty breastfeeding. So depressed moms not only breastfeed for shorter durations, but they usually will experience breastfeeding in a more negative light than non-depressed folks. So not only is their attitude towards it, their willingness to do it, but also they will typically breastfeed for shorter periods of time. There is an increased sleep disturbance in new moms. And again, I harp on this a ton, but the last thing we need is more things contributing to sleep deprivation with new parents, right? So poor self-care and also infant care. When someone has just had a baby, whether that was through C-section or vaginal birth, there is a lot of self-care that has to happen. There is a major healing that has to happen. So self-care is really, really important. Obviously, infant care is incredibly important. And those things can really fall to the wayside with untreated depression going on. We also see difficulty with bonding or attachment. Sometimes we see parents saying, like, I'm not feeling it. I'm not feeling connected. I mean, I'm here and I'm doing the things, and like, I know I've got to feed the baby, but I'm not feeling happy about it. I'm not feeling connected. And also we see a decrease in adherence to follow-up appointments. There are a lot of follow-up appointments for a newborn baby, right? And so those things are really important to make sure that weight is tracking and make sure that everything looks good. And sometimes those can fall off with a depressed parent. So some of the risks for baby that we found are, we can see increased crying. So these babies can also be harder to soothe, which is this cascading effect, right? So if you've got this baby that has increased crying or is harder to soothe, that also is a risk factor for depression, for exacerbating that depression. So it becomes this big snowball effect. We also see decreased levels of dopamine and serotonin in newborns, delayed fetal heart rate and responsivity. We also see what is really interesting is that when we look at the brain activity of these newborns, it tends to mimic that of depressed adults. And so it's clear that the effect on parent, even once baby is born, is palpable and is really, really noticeable. So if mom, if dad, if family is well, then that puts baby at the best position to be well. If mom, dad, parents are unwell, it really does put baby at risk for being unwell also. Okay, next slide, please. All right, so now let's look at some of the effects of untreated anxiety postpartum, right? So, man, postpartum anxiety, I know we talk a lot about postpartum depression, and it definitely is a common thing. But postpartum anxiety is also really, really common. I think honestly, in my practice, I probably see more postpartum anxiety than I do postpartum depression. So it's very, very common. I think we also tend to normalize a lot of that anxiety that happens. So it's, I think, goes untreated quite a bit as well. But for moms in particular, we see, and dads and non-birthing parents are also at risk for these postpartum depression, postpartum anxiety, any of these things. It's not just moms, so that keep that in mind as well. But we do see an increase in sleep disturbance in moms. And an increase in developing OCD. So something I'm always keeping an eye on when I see postpartum anxiety is I'm keeping an eye on that threshold to where it might kind of morph itself into this postpartum OCD presentation. We don't have time today to get into exactly what that looks like, but we are going to go into great depth with all of these different things in our 8-session series next year. So we'll kind of talk about the difference between anxiety, OCD, psychosis, things like that. But I am always looking for, parents are at a much higher rate of developing postpartum OCD if there is the presence of an untreated postpartum anxiety disorder going on. Also, substance use, unfortunately, a common help fix, starts as a problem solver, finishes as a problem itself. For this anxiety. So you'll see parents who just, I just am going to have this glass of wine. I'm just going to have this beer. I'm just going to drink a little at the end of the night to take the edge off. And sometimes that can turn into a really big issue, a big problem. So we also see some risks for baby if mom or dad is unwell and is having some anxiety in the home. We do see an increased fight or flight activation in babies, right? So that increased startle response is pretty prominent in these babies. Also, increased difficulty in learning new tasks. We see some of that carryover effect, right? Increased anxiety, fear in these infants or even into childhood. Anxiety, I will often say anxiety is one of the mental health issues that is actually contagious, right? Because anxiety can be picked up through families and through cultures and through, we can feel it in a room, right? And so that can happen within our homes as well. These babies are also harder to soothe. And then that persistent elevation of cortisol that we talked about in pregnancy can also disrupt that developing brain, right? So there has been studies that have shown the effects on the hippocampus, the amygdala, and the prefrontal cortex. Also, all of that put together ultimately can impact learning, memory, emotional behavioral adaptation, things like that through infancy and through childhood. So these really are impacts that we want to look at. Although these disorders and these struggles are typically temporary, sometimes the effects can be a little bit longer lasting. All right, next slide, please. So now let's talk about screening. So something that I think is important to put into perspective is, we saw that perinatal mood and anxiety disorders are the #1 most common medical complication of childbearing, right? So we have all of these other things that we screen like crazy. We screen like mad, right, with our pregnant folks for gestational hypertension, for preeclampsia, for gestational diabetes. Well, we see gestational hypertension at a rate of 6 to 8%, preeclampsia at a rate of 6 to 8%, gestational diabetes at a rate of 6%, but perinatal mood and anxiety disorders we see at a rate of 21%. And there has historically been a lot less screening happening for these much more common medical complications, right? So really seeing the need here for some of these really good screening tools. So who can screen, right? How does this happen? How do we do this? Anybody can screen, right? All providers who interface with pregnant, postpartum women, dads, non-birthing parents can screen for this. So OBGYNs, primary care, internal medicine docs, pediatricians, hospitals, child educators, lactation consultants, nurse midwives, therapists, counselors, OTs, speech and language pathologists, right? Anyone who is interfacing with a parent of a very small child can help to screen, okay? And I want to also next, and we'll go to the next slide, is introduce you to what I think is largely seen as one of the best screening tools for perinatal mood and anxiety disorders. So this is the Edinburgh Postnatal Depression Scale, or the EPDS. So I know it's really small, but that it can be used in pregnancy and postpartum, right? It is a 10-item self-report assessment. It's free to download and free to use, which is always good. It is translated into a ton of different languages. Little note that it's meant for screening purposes, as most of our screeners are. It's meant for screening purposes, not specifically to be diagnostic, but it really does help to give that sense of whether we want to watch a little bit more closely or refer out. So a score of 10 or higher really warrants some more investigation or a referral to a mental health specialist. And that score of 10 in mothers or birthing parents, and that score of 5 to 6, the threshold's a little bit lower in fathers and non-birthing parents. So this is something that you can use. It's really easy, it's pretty quick, and it can really help. There was a study that was done in 2000 in an outpatient OB practice, and I just think this is so fascinating with the EPDS. There was 391 outpatient patients in this OB practice. The women were screened using the EPDS alone, right? So with screening with the EPDS, the rate of detection of postpartum depression was 35.4%. The rate of spontaneous detection without screening was 6.3. So that right there really shows us that we can miss this a lot, right? And if we go to the next slide, I can show you, this is a recommendation for I think gold standard screening schedule, right? Again, this may look very, very aspirational, but if we could even move closer to something like this, that would be very, very helpful to get these parents recognized and get them the help that they deserve before it gets worse and worse. But a recommended screening schedule for this is at the first prenatal visit, okay? Also, at least once in the second trimester, at least once in the third trimester, ideally at the 6-week postpartum OB visit, or at whatever week that postpartum visit is. Also, ideally, repeated screenings at 6 or 12 months in either primary care, family practice, or OB settings. And then, and I think this is really important, is the 3, 9, and 12-month pediatric visits. So our pediatric providers have this unique opportunity to interface with parents of new children. Not only do babies and young children have a lot of appointments, right, often, but parents a lot of times are more motivated to get care for their children than they are to get their care for themselves. So this is really important, that pediatricians can really, and pediatric offices can really help with this screening and get those referrals out. So something to keep in mind for our family medicine folks, and if we had any pediatric folks on here too. All right, next slide, please. So this really this will wrap up kind of what I wanted to present to you today. Just some of the key points for you to take away is that perinatal period, remember, it includes all of pregnancy, right? All the way through that first year of birth. And any of these symptoms can begin or show in any period of time within that window. So the risks related to, and this is really, I think, the biggest takeaway, the risks related to untreated perinatal mood and anxiety disorders often outweigh the risks of treatment. And that's something that is very, very important to remember, is that yes, there are risks to treatment, but often the risks of not treating it is higher for both parent and baby. Proper screening is key. It's also really easy and accessible. And then also these disorders, fortunately, are really, really treatable. They are often really temporary. If you can catch them sooner, if you can get the right interventions in place, they are very, very treatable and can be really temporary. So a couple of resources here. Mass Gen, their hospital center for women's mental health, and their website right there is a wealth of information, right? We also have the National Maternal Mental Health Hotline. That's the number. This is a 24-hour or 24/7 hotline, both in English and Spanish. It's also interpreted in 60 other different languages. This is a really, really good number to have and for you to share with patients that might be struggling. Postpartum Support International is an organization that also has their website, has a wealth of information, tons of resources, most of them free for parents that are struggling. There's also a toll-free helpline. It's a warm line, not a hotline, in that it's not 24/7, but it's manned very often. It's also in English and Spanish. And then for you medical providers, there are, and for you prescribers, there is a perinatal psychiatric consult line that you can call and get in contact. Usually within 2 or 3 business days, you can get in contact with a reproductive psychiatrist somewhere in the country that can help you with any medication questions that you have if you're treating someone who's struggling, who happens to be pregnant or breastfeeding, that you're wondering about medications. And I know a few of our panelists, I think, have used that, so they can speak to that a little. They can speak to that more than I can. Here are some of the references if you're interested, and that sums up what I have for you today. Anybody have any questions?
Rachel, thank you so much. That was an incredible presentation. I want to open it up. Stephen, it looks like you already have something to say, so I'll let you go ahead.
Yes, thank you for putting that 800 number on there. That is a number of times I've referred to that since you started sharing that over the last couple of years. And people, the things that scare pharmacists, just so you know, is perinatal care. We don't want to give you bad information, and these are the experts. So that's who I would reach out to, definitely.
Yeah, it's a great resource. I think Michelle, maybe Corey, you guys have used it before. I think had maybe hopefully some good experiences with it.
Yeah, it's really useful.